when you watch cohorts of patients, and I'm sure you've been using these drugs in trials for a number of years now, Jason, there is this phenomenon of patients progressing over time. And I wonder, if you could give a sort of summary view of, kind of the patterns of progression. How do you respond to that? If you've given a patient PD-1 antibody monotherapy as a lead-in, what's your strategy? Do ipilimumab still on the shelf? What's your kind of tolerance or for amount of progression? Those sorts of things.
Mm-hmm. Well, this is definitely an area where the trials didn't necessarily allow us to do a lot of sequencing, but in clinical practice, we're sort of figuring it out anyway, just because we have to. Certainly, we do see, more rapid disease control with anti-PD-1 antibodies. And in my practice, I was talking with friends last night, I actually can't think of a patient that I have who had a response who has progressed. I know that there are those patients, but I don't personally have one. So a patient who has initial response, those patients do very well for a long period of time. Now, that being said, if patients have stable disease or not that much response, it's not like the patient's cured.
Sure.
I think that that's a misnomer. We think we have these drugs now and we have these great response rates. We still have a problem with melanoma.
Right.
And thinking about the sequencing issue, I think there is pretty good data now that suggests that anti-PD-1 antibody, absent other particular caveats, really ought to be the frontline therapy.
Right.
So a study led by Dr. Weber, and he can comment on it further, the 64 study looked at sequential ipilimumab, then nivolumab, or nivolumab, then ipilimumab, and the outcomes, as I understood them, was that the toxicity in aggregate it ended up being very similar, but that the response and disease control was better giving nivolumab up front. And given the toxicity profile of ipilimumab, I certainly would rather not give it up front if I didn't have to. Getting into the question about sequencing with the combination, I think it's even more complicated. And I have to say that my personal opinion right now is I prefer to use single agent anti-PD-1 antibody up front because it's robust, you get response rates, you get disease control, and you don't have this massive increase in toxicity profile. That's not a hard and fast rule. There are going to be individual patients here and there, but that's my preference when I think about frontline patients right now.
I would quibble a little bit with that. For two reasons. One is we have that really long tail with the IPI, that nothing comes even close, IL-2 maybe. But the other thing is we don't know how long to treat people with PD-1. One of the beauties of IPI is you get your 4 doses and you're done.
Right.
And then you're not coming in every 2 or 3 weeks or whatever it is to get your injection. Mentally it's better, and we know that response is probably going to be long lasting. Just as a little example, I had a patient a year or so ago when anti-PD-1s were approved, but you had to have prior IPI to be able to get them. So I had a patient with a big lung tumor, coughing up blood, the kind of patient you want a rapid response in. But I couldn't get the PD-1. So I gave him IPI with the idea of, okay, I'll jump through that hoop, give him 1 dose,
Sure, move on.
Call it residual disease, and he responded with 1 dose. Now he's a year out and almost a CR and a very rapid response, and no more treatment. So there's the occasion.
I totally hear that argument. I think that's where you get in with the patient-specific sort of issues, right?
Yeah.
But I think the data is pretty robust that suggests that frontline anti-PD-1 antibody, if you look at progression-free survival, response rate, overall survival, all of these things, point to PD-1 being. So I totally take your point, and that's where I think some of our practical research in the space needs to be in the future. How many doses of anti-PD-1 do you need? Right.
But also, the aggregate data is unarguable. But of course, you have a 40% response rate drug on one hand, and a 10% response rate drug on the other. And you can imagine a disease like melanoma that we always used to consider to be almost uniformly aggressive with a subpopulation that's somewhat indolent. I guess I'm wondering, is there anybody in your practice now, across your spectrum of patients by disease burden, high disease burden, middle of the road, low disease burden, indolent, small volume, it's real, it's unresectable, but still small volume. Is there anybody in that spectrum for whom this prospect of 4 doses is something you'd still think about?
Yeah, and I've done it actually.
Yeah.
So this is not a hard and fast rule. It really gets into the situation for the patient. A patient who's got small volume lung metastases, who's otherwise completely asymptomatic, you know, I have this idea, but I think for the general patient who comes in the door, you know, I think, you know, most patients when they're diagnosed with metastatic disease end up sort of ECOG 0-1-ish just to start,
Sure.
and then I have less tolerance for wanting to do that initially.
Well, I think that generally the data would strongly lead us to want to use PD-1 frontline. I mean, Jason was alluding to the 064 trial that Steve Hody and I led. The response rate for those who got nivolumab and then had a forced crossover, forced in the sense that it was an immediate crossover to IPI, had a 47% response rate with an excellent survival and excellent PFS. Those who went the other way, who got ipilimumab for 4 doses at week 12, and then had a forced crossover, meaning if they had failed, and 80% of them will have failed, and you immediately would treat them, which you generally would want to do, they had a 22% response rate and not as good an overall survival, which was very surprising. The only difference, they all got the same therapy, very few patients dropped out. It was a randomized phase 2 trial. The only difference was the sequence. That's a huge difference, and we're still trying to figure it out, but I think those data are sufficiently compelling that I would generally give PD-1 first and only hold IPI in reserve later. I would not see a good rationale for giving IPI first.
Let me torture you a little bit more on this point, Dr. Weber, because I think the point being that you know, in the subsets in which we practice, and no one clinical trial, particularly randomized phase 2 trials, really gives you a lot of granularity there. You can imagine that some patients with metastatic melanoma will progress in a 3-month, 4-month time frame to a point at which they may not be as responsive to whatever that second-line therapy is. So in other words, the IPI-NIVO sequence for some patients just may not get them to PD-1 quickly enough. The low disease burden indolent patient, lung only, you know, let's go further to say sub-centimeter multifocal lung only. You've been using ipilimumab in clinical trials and clinical practice for an awfully long time. What would you quote to be your ballpark response rate with what I said was a 10% response rate drug, but in that population?
I would tell that patient it's a 15% response rate because those with the low burden, with the M1A, M1B disease tend to do, as you would expect, better than the M1C visceral disease patients. And another 10% are going to be stable or will have progression followed by regression. So I give them a solid 1 in 4 chance of having significant clinical benefit.
Yeah.
If, on the other hand, it was a patient with bulk high LDH disease, rapidly progressive, I think we'd all agree those patients are less likely to respond to anything, particularly IPI. My concern is, I was at the chemotherapy symposium a couple of weeks ago, and it's one of those scenarios where you have these little devices where the docs render their opinion on questions, and one of the questions was, in a frontline BRAF wild-type patient, you would use what treatment? And they got a bunch of choices, and about 10-15% would still go with IPI alone. I said, and this was a relatively indolent patient with good performance status, low LDH, and I said, I don't think so. And I was up at the podium and I said, I think that the 6-4 data would lead me to go with Nivo or Pembro first, and then hold IPI in reserve. It's got double the grade 3-4 immune-related adverse event rate. It's got a 10-15% response rate, a clinical benefit rate of maybe 1 in 2 or 1 in 4, 25%, versus a solid 50+% clinical benefit rate for Nivo or Pembro alone. So I'm hard pressed to use IPI in front line. I think it's generally going to be a very good second line drug, especially if it's in combination with drug X, Y, or Z.
Sure. So